Even with little training in ultrasound in active labor, I suppose you had a lot of information from this video. Please answer the questions. What was the fetal heart rate? Could you see the placenta? Could you see the amniotic fluid still present or not? What was the fetal lie? Position of head and spine? What was the attitude? And what was the fetal presentation? The fetal heart rate was normal, around 150. Placenta anterior right. Still amniotic fluid present. It was a longitudinal lie. Occiput posterior position with occiput at 5 o'clock. You could see the fetal eyes and the nose at 11. The spine was at the same position. Perhaps a bit more challenging to see that this was a deflected attitude. You could see the spine posterior and deflected, and you could still see the fetal eyes above the symphysis pubis, and therefore it was a brow presentation. Fetal position. It's recorded like a clock, suggested by Akmal and her group. OA position, 10 o'clock to 2 o'clock. OP position, 4 to 8. Left occiput transverse, 2 to 4. And right occiput transverse, 8 to 10. Observe that 10 and 2 o'clock are included in OA position, and that 4 and 8 o'clock are included in OP position. Start with the transverse scan. You can see the midline, the cerebral peduncles creating a V pointing towards the occiput at 3 o'clock. However, when the fetal head is deeply engaged, it's more challenging to see the midline structures. But observe the short plexus. The plexus is diverging towards the occiput. And when you see this direction, you understand that the occiput will be here at 3 o'clock. In an OP position, you will see the fetal eyes and the nose up. If you still think it's difficult, do a longitudinal scan, observe the fetal spine or the fetal face, and then you can define the position. Rotation often occurs late in labor. Here a study from Hjartardóttir from Iceland. Early in labor, OP position was common, and 8 o'clock and 4 o'clock were the most common positions. However, late in labor, at full dilatation, most of the fetuses were in OA position. And also during a vacuum extraction, the fetal head has the possibility to rotate. Here, 120 women in OA position before a vacuum extraction, only 2 rotated the wrong direction to OP. In OT and OP positions, most of them rotated to an OA during the extraction. Fetal descent. Can fetal descent be measured with ultrasound? Levine from Paris had already 45 years ago a brilliant idea. He placed the ultrasound transducer on the sacrum and measured the distance to the fetal skull using A mode. Here is a signal on the sacrum, and here's the signal on the fetal head. And he could measure this distance. Nowadays, we do a transperineal scan. You can use a transabdominal 2D or 3D transducer, doesn't matter. Put on gel, a glove, and more gel. Preferable, use a sterile glove. Place the transducer between the labia in the fourchette. Move and angle this transducer and rotate to a longitudinal scan. First of all, you can observe the head direction. Early in labor, it's directed downwards, and late in labor, directed upwards, following the cardinal movements. Fetal station can be expressed as head perineum distance. It's a simple method, just one measurement. Place the transducer in the fourchette, compress the soft tissue, and measure the distance to the fetal skull. Here illustrated where the transducer should be placed. Remember to compress the soft tissue until you cannot come closer and meet resistance against the pubic bones. It's not uncomfortable for the women. Move an angular transducer, freeze the image, and use the cine loop to measure to see when the transducer is closest to the fetal head. Illustrated here, compressing the soft tissue, you can see the symphysis pubis, relaxing again, compressing again. Now I cannot come closer. I freeze and measure the distance. High station corresponds to 60 millimeter, mid station 35 millimeter, low station 20 millimeter. However, the most used method is the angular progression, published by Barbera et al. And the benefit of this method is that the symphysis pubis is used as a reference structure. You can draw a line through the symphysis pubis, and from the posterior part of the symphysis pubis, you draw a tangent to the fetal skull and measure the angle. It is easy. It requires a bit more training than head perineum distance, and both methods can be used, and they represent the same in a different way. I think you should train in both methods. Here, a longitudinal scan in the perineum. See the bladder, urethra, symphysis pubis, fetal head, vagina, and you can also see the rectum here. Be familiar with this kind of examining with ultrasound. And then you can measure the angular progression. On the left image, 120 degrees, amniotic fluid still present. Bit later, angular progression 140 degrees. Hjartardottir examined nulliparous women longitudinal during labor, and she found that in the first stage, the fetal head was usually above the mid-pelvic plane, represented here by the red line, and observed that the descent occurs rather late in labor, the last 3 to 4 hours before delivery. Head perineum distance getting shorter with fetal descent, angular progression getting wider with fetal descent. The movement of the fetal head is also an important variable. Look here, when this woman is pushing, the fetal head is moving a lot. We suppose this will be an easy delivery. The fetal attitude can be examined as the occiput spine angle, published by Guy and his group. He measured the angle between the cervical spine and the occipital bone. On the left image, early in labor, here the angle is 19 degrees. Later in labor, the fetal head is flexed. The movement of the fetus through the birth canal is different in OA and OP position. Here, an OA position, the fetus can follow the shape of the birth canal, and as soon as it had passed, the fetus had passed the symphysis pubis, it can extend the neck and the head be directed upwards. However, in OP position, the fetus has to pass deeper in the birth canal before the head can be directed upwards. This is important to remember when you do an operative vaginal delivery. Here, an OA position, see the direction of the fetal head upwards, symphysis pubis. And here an OP position, the symphysis pubis, and see that the fetal head is still directed horizontal or downwards, even though it's quite deep in the birth canal related to the symphysis pubis. So in OA position, you can just follow the birth canal, and the traction should be upward as soon as the fetal head has passed the symphysis pubis. However, in OP position, the cardinal movement is first flexion and then return to a neutral attitude. And when you do the vacuum extraction, you have to pull deeper down in a horizontal traction before you start the upward traction and return to a neutral attitude. When should you do the ultrasound in active labor? According to the ISWAL guidelines, when you have slow or lack of progress in the first or second stage of labor, you should do it before doing an assisted vaginal birth. You should know the fetal position before putting on forceps, and it's also important before a vacuum extraction that you know position, as I illustrated a few minutes ago. It's important because you also can have confirmation of the fetal head malpresentations. Remember this conversion table. Clinical station 0 corresponds to angular progression 120 degrees and head perineum distance 35 millimeters. And clinical station +2 corresponds to angular progression 140 degrees and head perineum distance 25 millimeters. So good prognostic signs before an assisted vaginal birth. In OA position, head direction up, angular progression 120 degrees, and head perineum distance less than 35 millimeters. But be more careful in OP position. Good prognostic signs, head direction up, also a flexed attitude, angular progression more than 140 degrees, and head perineum less than 25 millimeters, corresponding to station +2. Ultrasound has the potential to add clinical important knowledge. Ultrasound has the potential to reassure clinicians that a vacuum attempt at low stations has low risk of failure. And knowledge is not enough to improve outcomes. Understanding how to use the knowledge is essential. So my dream for the future, a labor room with a large screen on the wall where the midwife, the obstetrician, and the delivering woman herself can observe the screen, see the position, see the descent, and see if the pushing efforts are effective or not. Thank you very much.
Toby, and that was a really helpful and practical lecture about how you measure what you measure when you go through in a sequential manner from the transabdominal scan to the transperineal scan, and what the key measurements are, because I think it's very easy to get confused about all sorts of more advanced measurements, midline angle, posterior cervical measurements, all these, which are useful certainly if you've mastered the basic techniques, but actually it's relatively straightforward. Transabdominal scan, looking at head rotation, transperineal scan, head perineum distance, or angular progression. That's most of what we need for most of our cases. So I will ask Mauro to summarize, and then we'll move across to the next lecture.
Thank you, Christoph. As I did before, I will summarize this conference in Spanish, just briefly, in no more than 2 minutes. El objetivo de la charla del profesor Mo Egebo fue definir por qué, cómo y cuándo hacer ecografía durante el trabajo de parto. En el por qué da las justificaciones científicas y las razones lógicas de emplear el ultrasonido en las salas de parto para mejorar la atención y dar más seguridad a las embarazadas. En el cómo hacer la ecografía, repasa nuevamente las herramientas tanto transabdominales como transperineales que se utilizan en la actualidad para predecir el éxito de un parto vaginal en mujeres en trabajo de parto, y a través de, 1, determinar la posición de la cabeza fetal, 2, el grado de encajamiento, mencionando especialmente la simpleza de la medición de la distancia perineo-cabeza, y 3, la evaluación de la actitud fetal. Finalmente, en el cuándo hacer la ecografía, señala que siempre debería hacerse frente a la prolongación o detención de la primera o segunda fase del trabajo parto o previo a un parto operatorio. Y entrega además algunos mensajes prácticos sobre la relación de las mediciones ecográficas y el éxito de un parto vaginal. I just have done the brief summary of the third lecture that we have heard.
Fantastic. Thank you very much indeed, Mara. We move to our final lecture of this webinar, which is Professor Andrea Dal Asta from Parma in Italy. Andrea also works with us at Imperial. So, Andrea, you're going to talk about asynclitism and malposition. So perhaps some of the more advanced measurements and ultrasound techniques that we used. So over to you. And then, of course, we'll take questions. So if there are any burning questions, please do put them in the Q&A.
Good afternoon, and thank you to Professor Lees for the kind invitation to deliver this lecture on the intrapartum sonographic diagnosis of malposition and asynclitism, in which I will also cover the topic of malpresentations of the fetal head. In the previous lectures, we talked about the instrumental delivery, prediction of labor outcome, and in this lecture, we will also deal with a topic of major interest for obstetricians, given that looking at the indications for the primary cesarean section in a Western country like the United States, you can see that over 50% are attributed to malpresentation of the presenting part or labor dystocia. But if you look at the potential determinants of labor dystocia, you end up including malposition, malpresentation, and asynclitism, which basically represent the focus of this presentation. Why should we use ultrasound to spot malposition? This is because ultrasound assists in the identification of malposition of the fetal head, and this has been shown an association with the occurrence of cesarean section in women with labor dystocia during the first stage. Actually, we need ultrasound to spot malposition also because we have a high chance of getting it wrong with our fingers. As you can see from this data, when any of us examines a patient with his or her fingers, has a chance of a wrong diagnosis, which is about 1 in 4, and goes up to 1 in 2 if you consider fetuses in occiput posterior position only. And this is of course a problem because, as you all know, the knowledge of the occiput position is a prerequisite for safe instrumental delivery according to the international guidelines and also impacts on labor management. On this basis, it is not surprising that intrapartum ultrasound has been proposed with the aim to support clinical practice when evaluating the position of the fetal occiput, but also head station and attitude. It's also not surprising that the guidelines of the International Society of Ultrasound in Obstetrics and Gynecology endorse the use of ultrasound for the ascertainment of the occiput position prior to performing an instrumental delivery, and also for the objective assessment of malpresentation, which of course can include also asynclitism. So now let's get started and let's see how malposition can be spotted using intrapartum ultrasound. Intrapartum ultrasound can be performed transabdominally and transperineally. The transabdominal approach enables the assessment of the fetal head position and attitude. Starting from the position, you can see from this clip that you can see the kidneys on the axial plane, and then moving down towards the maternal pelvis, you get up to the baby's head, and by tilting the probe by 90 degrees, you can see sagittally the spine, which enables you to diagnose an occiput anterior. And while the visualization of the fetal occiput and spine allow to diagnose an occiput anterior position, the visualization of the fetal orbits by means of a transabdominal axial suprapubic view, which is shown in this image, allows to diagnose an occiput posterior position. It has to be acknowledged that based on available data, the ultrasound assessment of the fetal head position by means of transabdominal ultrasound is fairly more accurate compared to the digital examination in the correct determination of the fetal head position. Looking at the available data, also transperineal ultrasound may allow to assess the fetal occiput position with high accuracy, and this holds true particularly during the second stage of labor, which means when the head station is supposed to be lower. However, it has to be borne in mind that when evaluating the occiput position by means of transperineal ultrasound, different landmarks need to be used, in particular the choroid plexuses and the direction of the posterior horns of the lateral ventricles. We have seen how we can easily and accurately evaluate the occiput position by means of transabdominal and transperineal ultrasound. Now let's move on and see how we can spot malpresentation of the fetal head using intrapartum ultrasound. Transabdominal ultrasound also enables to evaluate the fetal attitude. In this slide, you can see an example of optimal fetal attitude with highly flexed fetal head on the left-hand side, and you can see that the malpresentation consists basically in a progressive change in fetal attitude from a flexed to an extended contour of the vertebral column. How can fetal attitude be evaluated by means of transabdominal ultrasound? As you can see from this slide, this can be done in first instance qualitatively, and you can see three pictures of three fetuses with markedly different degree of flexion, with a highly deflexed fetal head on the left-hand side, and on the other hand, a highly flexed fetal head on the right-hand side. Moving from occiput anterior to occiput posterior position, again in these cases, intrapartum ultrasound allows a qualitative assessment of the fetal attitude. This is a case of flexed fetal head in a fetus in occiput posterior position, and in this case, transabdominally, you can see that there is no gap between the chin and the chest of the fetus, while transperineally, you can see that the vertex is the leading part of the fetal skull. While in the event of mild deflection of the fetus in occiput posterior position, transabdominally you can see that there is some gap between the chin and the chest of the fetus, and that transperineally the leading part of the fetal skull is no longer represented by the vertex but by the sinciput. And finally, this is a case of extremely deflexed fetal attitude in a fetus in occiput posterior position. The deflexed fetal attitude can be appreciated transabdominally, and in this case you can see that the orbit can be visualized by means of transperineal ultrasound. And these are the features of a case of broad to face presentation in a fetus in occiput posterior position. Other than a qualitative assessment, it is important to bear in mind that also a quantitative approach has been proposed in order to assess the fetal attitude in non-occiput posterior fetuses by means of transabdominal ultrasound. The occiput spine angle is the angle comprised between the fetal spine and the fetal occiput, as you can see from this picture and from this ultrasound image shown in this slide, and has been proposed as a reliable and reproducible marker for evaluating quantitatively the fetal attitude in non-occiput posterior fetuses. Very recently, our research group has described the chin chest angle as a reliable and reproducible ultrasound parameter which can be measured by means of transabdominal ultrasound, enabling the quantitative assessment of the fetal attitude in fetuses in occiput posterior position. As you can see from this slide, the chin chest angle can be measured, is comprised by two lines, one which is drawn through the fetal sternum and the second one which is drawn tangent to the skin covering the inferior boundary of the oral cavity. What do we know about the implications of the evaluation of the fetal attitude in clinical practice? These are the data from the first manuscript by Guy et al. Describing the occiput spine angle, and you can see that in such cases a more favorable fetal attitude as witnessed by a wider occiput spine angle was demonstrated in cases of spontaneous vaginal delivery compared to those having an obstetric intervention. And in such context, a later study by our group confirmed the association between the head deflection at diagnosis of labor dystocia and need to perform cesarean section due to labor dystocia itself. And this was found to hold true for fetuses in non-occiput posterior position, as is the case of this slide, for fetuses in occiput posterior position, whose fetuses are shown in the table presented in this slide. Furthermore, the findings from this study from our group, which was conducted on a selected population of fetuses diagnosed with the protracted active phase of labor, suggested that the assessment of the fetal attitude may allow to discriminate between the cases having a cesarean section due to labor dystocia secondary to a malpresentation of the fetal head, which are basically those featuring high station in association with the head deflection, and those having a cesarean section due to labor dystocia secondary to a suspected cephalopelvic disproportion, which in this slide are circled in red. When thinking of cephalopelvic disproportion, we believe that these fetuses are featured by a favorable indicators of fetal attitude in association with high station and indicators of obstructed labor such as caput and molding. And recently, we discussed our hypothesis in a letter which is herein presented. Moving on from position and malpresentation, let's see now how we can spot asynclitism using intrapartum ultrasound. Synclitism consists in the malalignment of the fetal head in relation to the different sections of the birth canal, which determines the fact that one of the parietal bones of the fetal skull precedes the sagittal suture. Anterior synclitism, which is on the left-hand side of the screen, occurs in those cases where the anterior parietal bone precedes the sagittal suture, while posterior asynclitism is featured by the opposite, which means that the posterior parietal bone precedes the sagittal suture in the birth canal. Seeing that the transabdominal approach aids in the assessment of the position and presentation, actually the transabdominal approach has been proposed also for the intrapartum ultrasound diagnosis of asynclitism. In this slide, you can see that the probe must be positioned suprapubically on the axial plane, and for the diagnosis of asynclitism, different ultrasound signs have been proposed. Possibly the most popular ones are the squint sign and posterior squint sign, which basically consists in the suprapubic visualization of the anterior or the posterior orbit, respectively, in the event of anterior and posterior asynclitism, respectively. Actually, I do believe that the easiest way to demonstrate asynclitism by means of transabdominal ultrasound is the visualization of the midline of the fetal brain and particularly the assessment of its symmetry. The midline of the fetal brain is easily seen with sonography and represents a convenient proxy of the sagittal suture. Therefore, a downward displacement of the midline indicates anterior asynclitism, while an upward displacement of the midline of the fetal brain is suggestive of posterior asynclitism. However, I hope you agree with me that in most instances, asynclitism becomes a problem in late labor, which basically means when the head station is low. In such cases, the transabdominal approach may not allow a comprehensive assessment of the midline of the fetal brain. However, as you can see in this slide from this clip, the midline of the fetal brain can be nicely visualized also transperineally. This is actually a case with no features of asynclitism. If you consider cases of asynclitism, their main feature on transperineal ultrasound is that the midline of the fetal brain cannot be visualized on the standard transperineal axial plane. In this case of anterior asynclitism, as you can see from the picture, the midline cannot be visualized with standard angle of inclination. However, in anterior asynclitism, the midline can be visualized by moving the probe towards the pubic symphysis and at the same time by tilting the probe caudally in order to target the ultrasound beam towards the maternal sacrum. Conversely, the diagnosis of posterior asynclitism can be obtained by performing the opposite maneuver, which basically means by moving the probe towards the maternal sacrum and at the same time by tilting the probe towards the pubic symphysis. This was a case which we published a few years ago, and you can nicely see at the top of the screen that using standard angle of inclination, the midline cannot be visualized. However, by moving the probe towards the maternal sacrum and tilting it upwards, you can nicely see, as pointed out by the arrow, the thalami, and symmetrically the midline of the fetal brain. Other than anterior and posterior asynclitism, another subtype of asynclitism, which is lateral asynclitism, has been described in a case series of cases of protracted active phase of labor. And in this series, the authors reported this rare malpresentation, which is characterized by the lateral orientation of the head in relation to the trunk, and that with transabdominal ultrasound is featured by the visualization of the fetal chest together with the facial profile on the same plane. Last but not least, intrapartum ultrasound can allow the diagnosis of other types of malpresentation, such as compound hand-cephalic presentation. This is a case which we published a few years ago, where you can nicely see that the hand was anterior to the presenting part in the birth canal. This is another case which we recently managed in our labor ward in Parma. I just wanted to share these pictures with you. These, I believe, are very nice views which confirm the malpresentation, again featured by the presence of the hand, which precedes the head in the birth canal. That malposition, malpresentation, and asynclitism of the fetal head are risk factors for protracted active phase of labor and labor arrest, leading to obstetric intervention. And if you look at the guidelines of the International Society of Ultrasound in Obstetrics and Gynecology, you can see that other than for the ascertainment of the head position and station before considering or performing an instrumental vaginal delivery, and for the objective assessment of the fetal head malpresentation, the guidelines also endorse the use of intrapartum ultrasound in the event of the labor dystocia during the first or during the second stage. In such context, we believe that the use of intrapartum ultrasound has the potential to support clinicians in identifying the cause of a protracted active phase of labor or a labor arrest during the second stage, and allow an etiology-based management of labor dystocia itself. This is the algorithm which we propose for the ultrasound-based classification of labor dystocia. And as you can see, in the future, we may come to a point where improved knowledge on ultrasound in labor could allow an individualized labor management based on the most likely determinant of the labor arrest itself. We just need to wait and see whether this approach could lead to improved labor outcomes for our patients and also for their babies. And that's all for me. I thank you very much for your attention.
Andrea, thank you very much indeed for that very comprehensive lecture of really more advanced techniques. So if those of you that are listening are grappling with the intricacies of intrapartum ultrasound, then we've heard from Torbjörn about the basic techniques, and we've just heard from Andrea about the more advanced techniques, many of which actually still need to be fully evaluated in prospective studies, but at least show that it is possible to understand mechanistically, from an ultrasound point of view, what is meant by asynclitism, what is meant by deflection. So I think they give us a very helpful handle on that. Mauro, you are going to summarize Andrea's lecture, and then we'll go to some questions and answers.
Yes. Thank you, Christoph, and thank you to Professor Dalasta as well for the fantastic conference. El objetivo de la última charla del profesor Andrea Dalasta fue demostrar cómo diagnosticar asinclitismo, distosia de posición y distosia de presentación del polo cefálico durante el trabajo parto. En relación a la distosia de posición, esta se evalúa a través de visualizar la posición del occipucio anterior o posterior por vía transabdominal. La distosia de presentación del polo cefálico se realiza a través de la determinación ecográfica de la actitud fetal o grado de deflexión del polo cefálico, la cual puede evaluarse a través de medir varios ángulos por vía transabdominal, así como también a través de la visualización de ciertos puntos de reparo por vía transperineal. Por último, el asinclitismo anterior o posterior también puede ser diagnosticado a través de obtener algunos puntos de reparo tanto transabdominales como transperineales para polos cefálicos más encajados. Christoph, that is fine.
Okay, Mauro, thank you very much indeed. So we come to the questions and answer session of this webinar, and we've got quite a number of questions. So I'll direct the questions to our excellent speakers. So the first question, there are a lot of questions about how do we as delegates hear the lectures again, and how do we log in and see them. So I've asked Samsung just to respond so that everyone is aware of how they can access these lectures again, just in case you've missed part of a lecture. I know that in Ukraine we've got some comments here that unfortunately the electricity supply is difficult, so we'll of course do our very best to see if we can bring you those lectures fully so that you can enjoy them. We'll hear about that a little bit later, possibly from June. Let's go through some of the questions. The first question is from Nagwa Ibrahim. Most of my duty is in the labor ward. How can I do it? I think ultrasound in a simple way with the parameters transvaginal or AUS, which I suspect means abdominal ultrasound. I'll answer that question because it's relevant to all the talks. This is not about transvaginal ultrasound scanning. This is about transabdominal scanning using any ultrasound machine with a decent abdominal probe, abdominal ultrasound scanning, and transperineal scanning. So the important thing is there's no requirement to do an invasive or intrusive transvaginal scan in labor. Thank you for that question, because it's often misunderstood that in the labor ward we're not doing transvaginal scans by and large. There may be an indication to do a TB scan, but that is very rare. I'm going to ask Torbjörn to answer this next question. Is a linear probe better than a convex probe for symphysis distance?
Yes, it might be helpful in exactly this specific measurement, but we need to use the same probe for all the measurements, and we need to have a wide sector to have a good overview. I've tried using the linear probe, but I found it not very helpful. I would really need a huge probe to have a good overview. So these small linear probes we have today, then we only have a very small sector, and it's not a good idea.
Okay, so a wide sector probe, preferably curvilinear, rather than the small linear probes. And of course, a small linear probe is quite difficult to balance on the perineum, isn't it? It's much better. I actually use a 3D probe where I can get to one.
I usually use a 2D probe now. I think it's exactly the same if you use a 3D or 2D. Both can be used.
Yeah, No, that's
You can
that's fine.
use simple ultrasound devices, but of course we want to have as good and clear images as possible. So the companies should make high quality, small ultrasound devices.
Yeah, yeah, I agree. Good. A question here from Jessica, I think Brasky. I'm sorry if I've mispronounced your name, but thank you. Very interesting. I'm an O&G consultant in England, very familiar with ultrasound to confirm position, but not with all the various measurements presented. How prevalent is their use in UK obstetric units, and are they part of a trainee's curriculum now? So I think very many units will do intrapartum ultrasound to confirm position before an assisted delivery, probably a minority in truth. And yes, the curriculum, it is required to do of the RCOG curriculum, which changed just 2 years ago. So I think it's fantastic that actually ultrasound in labour is now on the curriculum. There is a real difficulty here in that it is not easy to teach intrapartum ultrasound because you can't teach it really in the way that you normally teach ultrasound with 2 or 3 people in a room around a patient and scanning. But I've got good news because we are developing a simulation methodology that will allow measurement of, for instance, cervical dilatation by transperineal scan. It'll allow AOP, angular progression, and head perineum distance. So I'm very much hoping that that will be ready to demonstrate at the birth conference in Milan. So Giancarlo Lorenzo, Roberto Romero are running a birth conference in Milan in early December, in 3 weeks' time. And I'm very much hoping we will have something to show then. Torbjörn, you
Can
have
I just add that this would be fantastic to see this training device, but I would also like to add to you, it's possible to train before start of labor because all the measurements can be done also before start of labor. So at the time of induction of labor, it's a good situation for training these methods.
Yes. No, I agree with, absolutely agree with that. We have a further question that I'm going to direct to Larry, actually. Do you agree if all intrapartum ultrasound should be done from the beginning of the expulsive phase or before?
I think I take it that the expulsive phase means the pushing phase. And
yeah, I'm assuming so too.
I think it's very important that one realizes that the measurements change without pushing in comparison to when the mother pushes. And there was a paper published in the AJOG with an MRI study of this last expulsive push before delivery of the head. And the angle of progression change that was measured from the beginning of the contraction to the delivery of the baby was quite dramatic. So it makes a very big difference when you do your measurements. And at rest or with contractions, it makes a big difference. And I think that has been one of the problems with a lot of the studies that have been performed. There's been no clear definition of when the parameters were actually measured, but there's been, with time, I think, a growing understanding of the differences, and there's more collaboration between the two measurements at these two stages. So there's better interpretation of the results of these studies now.
Okay, thank you very much. I'm going to ask a question to Professor O. And in measuring the pubic arch angle, Professor O, is it better to use 3D or 2D measurements?
Measuring pubic arch angle using 3D ultrasound may be more accurate, but pubic arch angle measurement with 2D ultrasound has advantage compared to 3D measurement because it is applicable by all ultrasound machines and transducers and is more easily used bedside.
Okay, all right. Thank you very much. And there's another question here for you. We talk a lot about ultrasound measurements in mode of delivery. What about the maternal pelvis, thing that we haven't really particularly talked about. Torbjörn showed a slide of measuring the maternal pelvis, a maternal pelvis parameter. How important is the pelvis? Can we measure it?
Yeah. Maternal pelvis is one of the predictor, one of the component which can predict the labor and delivery. We can evaluate the maternal pelvis using X-ray pelvimetry before labor, but X-ray pelvimetry was found to increase the cesarean section with no influence of perinatal outcome. So, however, because we can measure pubic arch angle with ultrasound, and there is a significant positive correlation between pubic arch angle and interspinous diameter, and between pubic arch angle and obstetric conjugate diameter. And so we can use the pubic arch angle to predict labor outcome. So we need to use the pubic arch angle in future.
I actually think the pubic arch angle, or just looking at the pubic arch, imaging it and feeling it is very important in an assisted vaginal delivery. I always get very concerned. I don't know how Larry feels about this. Torbjörn, if the arch is very narrow and the head is largely above it, even if the station is apparently quite low. I'm going to ask a question to Andrea. Andrea, you have mentioned two interesting additional parameters, the occiput spine angle and the chin chest angle. If people want to understand more about that, where can they read about that, and how have you precisely defined that? Because of course, putting angles is always a bit difficult in fetal medicine. We do it for micrognathia and for other conditions, but obviously placement of calipers is very, very important.
Thanks, Christoph, for the question. Yes, it is definitely very important. Well, actually, I believe that particularly for people who have some sort of expertise in antenatal ultrasound, I don't think these parameters are that much difficult. With respect to the occiput spine angle, you could see in my lecture that there is the reference is a paper published with the first name Professor Guy, published in 2016, and basically looking at the definition, the angle is encompassed between the cervical spine and the fetal occiput. Of course, you need to draw two lines tangent to both the cervical spine and the fetal occiput, and then measure it. And of course, this adds with respect to the qualitative approach, because it's much easier to compare, particularly if you want to evaluate not an uncomplicated labor, but a complicated labor with dystocia, which is the degree of deflection, and based on our experience, also the likelihood of, or let's say the most likely determinant of the dystocia, which could be, as we showed, either CPD or deflection itself. On the other hand, the chest angle may need maybe a bit more challenging. We have described this parameter last year, and the paper is got myself as first name. The technique is a bit more difficult. We recently demonstrated, but we're yet to publish data reproducibility. But the angle can be measured by drawing two lines, again, one through the longest axis on the sternum, and another one just through the skin covering the inferior boundary on the oral cavity. This is the definition. I believe it is much more difficult to explain than to see, because when you get the right view, it's pretty much straightforward for people who have skills on antenatal ultrasound.
Okay, all right, but I think that there's a slightly more advanced parameters. So really, we should probably have a basic and advanced parameter definition, shouldn't we? And it'd be quite good actually to have a table of those to explain exactly where all these are measured. When we wrote our ISWA guidance 4 years ago, of course, not all these more advanced parameters had come into use. Good. Okay. Well, I think we'll. Sorry. Yes.
Can I say something? Can I
Yes,
ask,
of course.
Maybe a question, because I was wondering about one of the questions that was already sort of answered readily. But I would like to sort of make it again, because I think it's a very interesting question. The question was, do we have a prediction model made of all these markers? So we can calculate a score for possibility of a successful delivery. I think this is quite interesting, because we have a lot of predictive models for preterm delivery, preeclampsia, aneuploidies, etc. So I think it's a good idea, but I think would be nice to hear here what these expert thinks about this.
Okay. Well, I can answer that, and then I think Torbjörn may be able to answer that as well. So we're doing a lot of work here at Imperial on exactly this prediction models, and published together with Torbjörn in 2015 the first stage ultrasound prediction model, which worked reasonably well. We've refined that since then, and based on an ultrasound, initial ultrasound scan in labor, so usually in early labor, the area under the curve, the AUC, is about 0.8485. So it's reasonably decent prediction for intrapartum cesarean delivery. And it gets a bit better if a repeat measurement is used. Now, that is actually available on the intrapartum app. You can find it on the Google Play Store, and elsewhere as intrapartum. If you look at intrapartum, it's a completely free app. So that's based on the 2015 prediction model, which we have now significantly improved. We haven't added that to the app yet, that algorithm to the app. We're just waiting to recruit a few more women. Arwa Hanidou here and Maria Kovalenko are doing that and supplementing the work of Sana Usman. But that's a first stage prediction model, and it does work, though not perfectly. Torbjörn, you want to say something?
Yeah. I also think that it will be very, very interesting to have a predictive model like this, and especially at admission to the labor ward, I think. In my experience, it's very, very difficult to pick out women that should, before labor starts, at induction time, to really pick out someone that should go directly to cesarean sections. I think usually they should try the labor.
Yes.
But the predictive model at admission, I think it will be very good to have.
Yes, and there's often concern that using prediction models will end up converting women to cesarean section. In fact, exactly the opposite is true, that if we look at our prediction model, we are much more frequently reassuring women, we would be much more frequently reassuring women that they can have a vaginal delivery where they're uncertain about that, rather than suggesting that they're likely to need a cesarean. Andrea, very quick comment before we close up.
Yes, but with respect to prediction models, yes, I just wanted to add, as I showed in my presentation, that it's not properly a prediction model in terms of numbers, but we propose that, of course, you can predict the success of labor, which could be related to the mechanics of labor or to the placental function, let's say. So you just need to decide which are the parameters to be taken into account. But with respect to labor dystocia, as I showed, we propose this this sonographic classification, which needs a little bit of work, but in the future could allow an individualized approach. This is not properly a prediction, but of course, if you individualize the management, you may end up having better outcome for mothers and babies, which means that you can bring forward labors that have a good chance of being successful despite the dystocia, while on the other hand going towards cesarean section when you have very little chance of vaginal delivery. And we think this is something this code needs a lot of work and practice, because we're integrating different parameters, but again, we believe this is the future in the field. So very good, very important to draw these predictive models and classifications for future research.
Okay, let's hope that if we run a webinar in 2 years' time, then we'll be able to present a fully configured prediction model. That would be wonderful. Good. All right. I'm going to close there. I think we've had excellent summaries. Thank you, Mauro, for co-chairing and presenting the summaries of the lectures in Spanish. I think that's wonderful. I'm delighted to thank Samsung for supporting these lectures. These lectures are hosted and brought to you by Imperial College Consultants, and we're grateful for Samsung for supporting these educational activities. And I'm going to allow June to close, and perhaps June, you'd say a word or two about our final webinar of this year, which will be in December.
Well, thank you, Professor Lee. I'd like to thank our attendees for taking time out of their busy clinical commitments to be attending the East Meets West webinar series sponsored by Samsung. The webinar has been recorded, and a separate on-demand link to access today's webinars will be sent to your email account that you've used to register for this webinar. Also, for those who have provided us permission to contact you via email. So you will be getting an access account. This will be free of use for the next 8 weeks starting tomorrow. And I would like to thank our Imperial College Consultants, our co-moderators, Professor Christoph Lees and Professor Mauro Para. It's not easy to translate one language to another, and I think you did an excellent job. Thank you very much for that. And also, I'd like to thank our speakers, Dr. Larry Hinkson, Professor Min Jong Oh, Professor Tobio Moye Egebo, and Professor Andrea Dall'Asta for being an excellent speaker and an advocate for intrapartum ultrasound. And thank you all for being with us, and I hope to see you again in our next webinar series. And for all those, good morning, good afternoon, and good evening, everyone. And also, please do not forget to take part in our survey, which will provide you links at the end of this webinar. Thank you.
Thank you.
Bye-bye.
감사합니다.
Thanks all.
Bye all. Thank you very
Bye.
much.